Hi, I'm Mandy Kenny and it's fantastic to be here. I'm going to start by painting a really gloomy picture, but hopefully by the end of me speaking you'll feel really passionate and excited about the opportunities that arise from the challenges. Internationally, we're really heading towards a crisis in health, not only rural health. We have an ageing population, a huge exponential increase in the baby boomer generation. And what that means is that we have this massive population that is rapidly ageing, but the generation coming before them are much, much smaller. The other thing that we know is that people will be living much, much longer and living much longer with chronic disease because we're all too fat, diabetes, and all of the other problems that we know about heart disease. We also know around the world that we have major problems with mental health, and most of you would be aware of the terrible statistics that we see, particularly around the area of things like youth suicide. Now, those issues are really compounded by the significant problems that we have worldwide. We used to talk about workforce shortages, but we talk much more now about workforce maldistribution. And what we mean by that is having the needing to get the healthcare professionals in the right place. We have absolute significant demand for health services internationally, and it's not only in Australia, it's worldwide. And combined with that, that demand and the ageing population leads to a situation where we have spiralling costs. And even in Victoria, recently in the Age newspaper, they were reporting the significant deficits that health services were starting to post, where really the amount of money is nowhere near enough to deliver what we need in the future. And to put this in context, you have to remember that I'm really, I'm not that sort of young, but I'm at the very bottom end of the baby boomer generation. And really what we're going to see are these major problems occurring in the next 20 years as we age. The population now, very small numbers of people over 85, but the predictions are indicating that we will have this huge amount, particularly of females, because of course we live longer in that 85 age group plus. Now, when you actually think about the rural context, what we're really talking about is the issues that are occurring internationally in any healthcare setting, but they are exacerbated enormously by challenges related to access and equity. In rural areas, we have socially determined disadvantage. And when we talk about socially determined disadvantage, it's about lack of access to education, housing. When I present at international conferences, one of the things that I'm always really ashamed to talk about is the appalling state of our Indigenous people and the way in which there are significant gaps in the lifespan of our traditional people in this country and white Australians. We also have enormous problems in socially determined disadvantage with refugee populations, as many of those people that have been in our detention centres are being settled out in rural and regional areas. And we have scarce resources. And I'm a nurse, and I'm probably typical of the average nurse now, and that is that we're ageing. In many communities, nurses, the statistics tell us about nurses being over 50, but in many communities now they're over 60. And the problem is, if you think about those demographics, we don't have the numbers of young people coming through. We also have the challenges that we know that young people, the generation, are really different. They only want to work part-time. They don't want to work full-time. They want to change career frequently. The other problem that we have with our healthcare system is that it's very based on acute illness. We've built these fantastic hospitals that are really focused on ensuring that we deliver really good care when people get sick. But we know in the future we must change to a much more primary health focus. We need to talk about prevention and health promotion rather than moving to the point where people need acute care. In rural areas, the other thing that we know is that rural people face poorer health outcomes. And that's a generalisation really, because in some rural areas, the health status is very, very good. But across the board, we know that if you have breast cancer in a rural area, you are far more likely to have poor outcomes. If you have lung cancer in a rural area, you are far more likely to do much worse than somebody who lives in a metropolitan centre. Now, part of the problem is, of course, our healthcare system generally is largely designed by metropolitan bureaucrats. And I think internationally, whether it be in Australia, whether it be in China, whether it be in Europe, the United States, the United Kingdom, that much of our approach has been a one-size-fits-all approach. So we've developed health policy, we've developed ways to deliver health care, but in fact we try and apply that in whatever setting. And in rural areas, part of the problem is that whilst there is some commonality, many of the issues of geographic distance, socially determined disadvantage, we see that in China, we see that in Australia, but the solutions can't just be applied the same. There is commonality, but the one-size-fits-all has largely been unsuccessful. Our policymakers, when they produce policy, largely it is designed in this acute care framework and for metropolitan. 30 years ago, the World Health Organization, probably the most significant global statement on health was the Declaration of Alma Ata. And in 1978, they sent a very ambitious agenda of health for all. And they identified that the absolute key to health for all was really about the importance of communities and the importance of us as citizens really being able to think about planning, the design and the delivery of health services. But 3 decades later, while we still have this wonderful global ambition of individuals being actively involved to ensure that the healthcare services are the sort of services they need, we still have people quite disengaged, and in a rural context, we know that rural people still feel very disempowered and still largely have metropolitan policies imposed on them as a solution for their community. Now, one of the things that I think that's really gloomy, you know, we're the baby boomer generation. We're going to be facing this terrible healthcare system where there are no services, there are no health professionals, the costs are spiralling, and I think that you could get totally depressed about it. But my passion and my excitement really comes from thinking about ways in which we can respond. And I think that's what drives me as both a researcher and also trying to inspire particularly young people that rural health is the most fantastic career. But really, more importantly, the solutions that we can come up with really are solutions that will make an enormous difference to rural people. One of the things that we do know about rural people, and looking at this picture, is that they're incredibly adaptable and incredibly resilient, and that many of the things that occurs in rural areas is in spite of policy. And what I mean by that is people come up with solutions because they have to. They're very stoic, very adaptable and really creative. And as a rural nurse, I guess my creativity and my passion has really come from trying to make the best. Sometimes, you know, it's really hard, but it gives you the wonderful flexibility and freedom to really think about how you can develop solutions. So we know that we need to do things really differently. And we know that rural people are really resilient. And what we're now seeing is this push from policy to really focus much more on primary health, much more on ensuring that we have great health outcomes before we get to the where we need acute care services. What's also coming through, and it's been interesting reading the United States and the debate around health in the United States, and that is we're finally recognising in policy that global dream that the World Health Organization put forward 30 years ago about engaging communities is starting to really occur in policy, and saying that if we're going to get services that meet community need, they need to be locally responsive, and therefore we need local people who are born there, live there, age there, to actually have significant input into the way in which those services are delivered. Now, our work is really highly innovative and it's really fantastic and exciting. Traditionally, what we would do as researchers or policymakers is go into communities and we'd ask them what they think, we'd hold a public meeting, or we'd get them to fill out a questionnaire, and then we'd go away and develop up all these wonderful recommendations and solutions and impose them on that community. And what we would say is that we have engaged with the community. Sometimes we've already decided what we want to do before we even go, and it's about placating the community, making them think that they've had input. We're working in 3 rural communities in Victoria. So we're working in rural Northwest Health in Warwick-Nabil, and you can see on the map, in Rochester and in Heathcote, and I'm based in Bendigo. And those distances might seem, when you think about Victoria, that we're not very rural. But in fact, the challenges that those communities face are significant. If I use Heathcote as an example, which is 123 kilometres from Melbourne, the issue with Heathcote is that there's very little public transport in that community. If you are old and you need to go to a medical appointment, even in Bendigo, which is only about half an hour, it might require you to catch the bus at 7 a.m. in the morning for one doctor's appointment, and you're 85 and you have to sit there until 6 o'clock at night when the bus goes back. And so we often think about we're not very rural, but in fact we are in many ways because we're close to a metropolitan city, and so therefore the types of services they have out in remote Australia aren't the same. You know, you've got the flying doctors, but we're not covered. So the distances can be significant. What we're doing in these communities and why it's innovative, instead of actually going into those communities and doing this tokenistic participation, we've set up projects where they're true partnership projects. We're working with groups of community members, and our role as researchers is really to almost act as research assistants for those communities. So we're putting in place a process where the group community members, and particularly those that are very passionate and can really act as almost boundary spanners in that community as champions, we're bringing them together and we're actually really empowering them, I guess, by providing them with the information about their communities to make sure that their decisions can be properly informed. Rather than going and asking a community what they need, it's about really making sure that we balance that want and need. And so when they make decisions, for example, you know, they might want to be really keen on maintaining birthing services within their community, but the number of babies born are so tiny that the data that we can show them, the data that we can collect with them really shows that the major problem is with their older people. And so we're in a fantastic situation where these communities and the health services think that this is so important that they're funded, and we have 5 PhD students doing this work. Now, this work is really innovative because it is about moving, I guess, this notion of community participation to this next level. And when we talk about it in theoretical terms, Arnstein's work is really useful. And we talk about higher levels of participation. What I talked about earlier, where we go out to a community and we just talk to them, is really down at that notion of therapy, manipulation, maybe some consultation or placating them. The work that we're doing is really trying to push up to these higher levels of participation where communities can actually become really, really either partnered, but also can come up with solutions. I was in one of those communities a couple of weeks ago and the transport issue came up of the older people and no transport. And we were sitting there talking and somebody said, oh, we need to get a bus service that runs every hour. And somebody else said, no, it would be empty. What we need to do is like another community where they put a book in the local hotel and basically wrote in there, a great community solution, wrote in there who was going to the regional centre and people could book a seat in a car. And so I think what we're trying to do in the communities is to say, give them the information that they need so they can actually make really, really informed decisions, but recognising they are the experts. And so being able to support communities to move up into those higher levels of participation. And I think in closing, one of the things that's really important and exciting in our work is that internationally this is a problem. And you know, we're really driving research that will be significant in a world context, because there's so much about policy, but nobody knows how to do this well. And I think the last thing I want to say is that, you know, we see people as experts, and I guess the whole purpose of our work is to actually encourage policymakers to listen. Thank you.